Hello, my name is Alon Avidan and I direct the UCLA Sleep Disorder Center. I'm in the Department of Neurology where I serve as Professor of Neurology. I'd like to give you an introduction to insomnia and really review some of the causes, the evaluation of insomnia, and some ideas about management that we usually provide our patients. As a sleep physician, the vast majority of patients that I see have some sort of insomnia. They often present with difficulties with falling asleep, maintaining sleep, and often don't recognize that there are pretty simple and quick fixes to help improve the insomnia that don't really require a lot of medications and sophisticated evaluation. So what I'd like to do is give you some introduction into what is insomnia, what causes insomnia, and also how we treat insomnia. So if you have any questions, this is how you can log on to Twitter and submit your questions, and we'll take a few minutes at the end of the presentation to review and go through some of this. What is insomnia? Insomnia is defined as follows. Either difficulties with falling asleep, we call this difficulties with sleep initiation, difficulties maintaining sleep, that is awakening that are undesirable in the middle of the night with difficulties falling back asleep, or early morning awakening. Early morning awakening is often a very comparable or potentially suggestive of depression. The next day consequences are really what defines insomnia as a disorder. And I'll give you some examples. When someone defines difficulties with memory and cognitive issues, when they describe difficulties with fatigue the next day, headaches, memory and cognitive disturbances, feeling depressed, those are the type of symptoms that we are really interested in, because just having difficulties with sleep initiation or maintenance without daytime consequences may not be a disorder that we need to treat. But if the patient has problems with daytime symptoms, that's really a red flag where we need to intervene with management. We like to think of a definition of insomnia to also include a frequency criteria, that is at least 3 times per week. For chronic insomnia to occur, we need 3 months of insomnia to occur at any given time. And again, when we look at sleep initiation difficulties, sleep maintenance difficulties, or early morning awakening, those are the type of symptoms that patients present with. Now they can have a combination of sleep initiation and sleep maintenance, or sleep maintenance only. Any of those would be sufficient for the diagnosis of insomnia. Now take a look at this. As we grow older, the rates of sleep disturbances tend to go higher, and so does insomnia. And it's not atypical for women right around the time of menopause to begin to express and present with insomnia. It has to do with hot flashes, has to do with depression, anxiety, more medications for other medical issues and psychiatric complaints that tend to increase with aging. Around late life, disturbances of dementia, neurodegenerative disease often make sleep disturbances much more difficult to treat. And they're often presenting with fairly significant insomnia. And the problem is they don't come to see the sleep physicians until they've had the insomnia for multiple years. And one thing I want to mention is that older adults need as much sleep as younger adults. And it's their disturbances of really getting a good night's sleep that is at the core of the issue. They need as much sleep, 7 to 8 hours of sleep, as let's say a 20-year-old. But their ability to sleep is really disrupted. And that's really the core issue, that when we address insomnia and treat it, we want to make sure that an older 85 or 90-year-old gets as much sleep, as restorative sleep, as a 20-year-old. We also think of insomnia as being transient or acute. That has to do with an exam or pain or hospitalization versus chronic insomnia, which tends to occur with depression and other medical and psychiatric conditions. To understand how we get insomnia and how insomnia evolves, we have to understand there are 3 P's. There are predisposing factors, there are precipitating factors, and there are perpetuating factors. And let me tell you what I mean by that. So, if we look at insomnia as occurring right here at the threshold, any patient who has insomnia right here expresses insomnia as a clinical problem. But you have to have predisposing factors, and predisposing factors include individuals who have an anxiety disorder or depression, or they're just having the symptoms of anxiety just before they're about to fall asleep. Those are predisposing factors that the patient has. There have to be some precipitating factors. And what do I mean by that? Well, precipitating factors can include issues related to pain, hospitalization, loss of a loved one, issues with jet lag. Let's say if you travel to Europe tomorrow, that's a precipitating factor for insomnia. It's going to precipitate the sleep issue, and then you have insomnia. You have clinical insomnia. Now, why does insomnia persist? Well, you have to think of perpetuating factors. That's the final P, the third and final P, perpetuation. And by that I mean issues that are related to poor sleep hygiene. Now, what do I mean by poor sleep hygiene? Well, caffeine too close to bedtime, alcohol. Alcohol is notorious for worsening the sleep architecture, causing multiple awakenings. People don't recognize that, but having a glass or 2 of wine before going to bed can really disrupt your sleep architecture. Other issues have to do with watching television or working on the computer just before bedtime, because the light from the computer screen is very disruptive. And we want to make sure that patients do not drink alcohol, do not have caffeine, do not smoke before bedtime, and do not watch television or work on the computers or answer emails or have any kind of abnormal light exposure that tends to be very activating. All of those factors, when removed, can lessen the intensity of insomnia, can actually even reverse the insomnia and improve the symptoms without using any medications. All right, so here's what I'm talking about. The picture is really worth 1,000 words. Here's an insomnia sufferer, and take a look. She has bright light. The hour is 3:20 a.m., and she has bright light. She's awake. She has a bottle of Jack Daniels behind the alarm clock. That's never a good sign in a patient with insomnia. Having alcohol, it's enticing because alcohol relaxes you, but it really fragments your sleep architecture once you fall asleep. It's really to a point where people begin to, after an hour or 2 after falling asleep, they begin to wake up again because they metabolize the alcohol and it's no longer active. So what would we tell her? How would we treat her insomnia? Well, when the patient describes that they're in bed and they can't shut off the lights and the arousal in their brain, sometimes they're talking about the on-off switch, and they can't find the off switch to all this rumination and thoughts that are coming at 2 or 3 in the morning. We tell them to get out of bed. We tell them to do something relaxing, boring book, and use a dim light, and when they feel sleepy again, they can go back to bed. The bed is really supposed to be used for 3 S's. The first S is sleep, second S is sex, and the third S is sickness. And you shouldn't be doing work in bed. No emails, no answering text messages, no computers with doing puzzles or reading the news or watching television and doing puzzles on your iPads. That's never a good idea. Here's a breakdown of some causes of insomnia. Take a look. About 2/3 of patients that we generally see probably have some underlying behavioral or psychiatric issues like depression and anxiety that generally presents as a untreated insomnia. But take a look. Sleep apnea can also cause insomnia. Especially sleep maintenance insomnia. So if you snore, you stop breathing at night, that tends to fragment the sleep architecture, and that's always a good reason to come to see your doctor to get further evaluation using a sleep study. And at UCLA, at the Sleep Disorder Center at UCLA, we conduct specific studies, a sleep study evaluation to ensure that the patient doesn't have sleep apnea or other motor disorders, other movement disorders that keep them awake at night, like periodic leg movements of sleep. That's very important to be able to rule out those conditions using a sleep study. Okay. Now, it's important because knowing the timing of the insomnia can help us appreciate the type of causes of the insomnia. So for people who have problems falling asleep, we have to think of anxiety disorders, restless leg symptoms, problems with sleep maintenance. Well, here we have issues with untreated sleep apnea, pain. Nocturia means frequent urination at night, and that is sometimes correlated with untreated sleep apnea and prostate enlargement in men. Poor sleep environment, living by the airport, having too much or excessive light exposure just around the bedtime is what we're talking about when we mention sleep maintenance difficulties. And early morning awakening, very synonymous with depression. So let's talk about sleep hygiene, because that's really the main issue, the main work that we usually recommend patients when they present with insomnia. And here are a list of some do's and don'ts. Most of you are probably familiar with this, but I'll review. Here's the first do. Enhance your sleep environment. Dark, bedroom, quiet, cool temperature. By cool temperature, I mean something around 68, 65 degrees Fahrenheit. Cooler is actually better because it allows for and promotes the secretion of melatonin. Increase light exposure during the day, not during the night. So we want to maximize light in the morning and afternoon. Relaxation routine, deep breathing. Some people do yoga before bedtime. Reduce the time in bed in which you are awake. So if you find that it takes you 15 minutes to fall asleep and you haven't fallen asleep, you need to get out. You need to move to a different room, and you need to pick up a boring book, and when you feel that you are asleep, you should go back to bed. Regular exercise, but in the morning or early afternoon, never too close to bedtime. Actually, regular exercise early in the day with maintaining a regular sleep-wake schedule is very, very effective. Here are some don'ts. Do not watch the clock. Why is that? Well, you're going to look at the clock and you're going to feel more and more frustrated why it is now 2 or 3 in the morning and you haven't been able to fall asleep. So get rid of the clock. No iPhones, no iPads, no computers. Get rid of electronics. I see a lot of patients who, if they can't fall asleep, they take the computer and they start doing puzzles while they're in bed. Never a good idea. The use of stimulants, particularly caffeine and tobacco, is never a good idea, especially too close to bedtime. If someone decides to have caffeine during the day, enjoy a cup of coffee or two, as long as they do that before 1 o'clock, it should be fine. Anytime after that, the caffeine is going to stay along in the bloodstream and can actually affect the sleep architecture. Nicotine, especially e-cigarettes and caffeine gums, should not be used too close to bedtime. A heavy meal, particularly with alcohol, within 3 hours of bedtime, never a good idea. Having a light snack granola bars, yogurt, banana, probably very helpful because it actually gives you a little bit more melatonin, and melatonin is very conducive to improved sleep. Use of bright light during the night and computers, as I've mentioned, never a good idea. Get rid of all electronic gadgets. We see a lot of students who come in and they have to do computer work, and they do that up until the very last minute before they go to bed, and they cannot fall asleep because the light exposure from the computers actually stimulates the circadian clock and keep you awake. So have electronic silence. No computers, no electronic gadgets that emit light in bed before sleep. Here are some of the 10 commandments for improving sleep. Maintaining a regular sleep-wake schedule. I think that's really important. You don't want to be sleep deprived one day and then make it up the next day. Sleep is not like a bank account. You want to get about 7 to 8 hours of sleep every single night. And more importantly, at the same time during the night on a consistent basis. Reduce your daily caffeine intake. We have already mentioned that. Turn off computers and television. Don't go to bed on a full stomach. Don't have a steak or a McDonald's before going to bed. But at the same time, don't go to bed on an empty stomach when you're feeling hungry. And when you do feel hungry, you can have a piece of banana, granola, some crackers with cheese, which can improve your tryptophan levels. Regular exercise, particularly early in the day. Limit your beverage consumption too close to bedtime so you can prevent those episodes of awakening because your bladder is full. Keep your bedroom dark and quiet, a little on the cooler side. Go to bed using your internal circadian clock. In our brain, there is a suprachiasmatic nucleus, which is really setting the sleep and wake timing. And we want to make sure that we're going to bed and waking up at the same time as to not to confuse the circadian clock about what is our regular sleep-wake timing. And usually if you have a mattress that's not very comfortable, you might want to invest in a mattress or a pillow that is more conducive for sleeping. Say no to alcohol. No to alcohol, no to caffeine, and no to tobacco. Despite that, up to 28% of patients will use alcohol before bedtime because alcohol relaxes them. The problem is when you fall asleep, you stop drinking, and then you wake up. And when you wake up, you perpetuate the insomnia. So I just want to show you, this is a sleep diary from a patient who woke up at 11 p.m., had scotch, fell asleep at 11:30, woke up at 4 a.m., had another scotch. He crossed it out, but I think he actually had it. And then fell asleep again at 4:15, woke up at 5:24, had another scotch. Really, it shows you how poor sleep is when you take alcohol, because every time he wakes up because the level of alcohol is decreased, only to have another drink to maintain its effectiveness. But alcohol can fragment your sleep architecture, make you have sleep apnea. If you just have snoring, it can disrupt your good quality sleep, and it has some issues with dependence, tolerance. Never a good idea to use alcohol as a hypnotic. You see, here is an example of a patient who wakes up and the light exposure is really keeping him awake. He should get out of bed, pick up a boring book, never surf the web, never watch TV, despite the fact that all these patients, this is a study from a patient, say, with their activities before bedtime, and take a look how many of them surf the web or watch TV or read the paper, read on their electronic gadgets. That's never a good idea. So the electronic gadgets should be eliminated. Pick up a boring book. But when you read, don't read in bed. Go to a different room in a house and use dim light, and never pick a spy novel or something that's interesting, like reading the news, pick up something that doesn't really interest you, something on the boring side, so you won't get interested in it and keep reading it until 3 in the morning. Regular exercise, no caffeine, no alcohol can equal good sleep. And what I'd like to go over in the next few minutes are some ideas about medications that actually can help you fall asleep. Those are called hypnotics. Hypnotics are medications that we use to help improve your ability to fall asleep. Dietary supplements, that includes melatonin or valerian. Melatonin actually doesn't have very good data about sleep issues with insomnia. It does for jet lag syndrome, for example. But here are some of the medications that we use specifically to improve sleep-wake issues specific to insomnia. And what these medications do is they target specific areas in the brain by blocking wakefulness and enhancing sleep. So for example, a benzodiazepine like a zolpidem or zaloplan or esapicolone, what they do is they enhance the inhibitory neurotransmitter in the brain that allows for improved insomnia. Drugs that block wakefulness include drugs like histamine antagonists, like drugs like Benadryl type compounds. But Benadryl, by the way, is never a good idea for sleep because it's, people wake up very groggy from it because it's not very specific to the histamine receptors. And there's a new drug that actually blocks orexin. Orexin is a neurotransmitter that facilitates and improves wakefulness. And we're making here people a little bit narcoleptic before going to bed, and that way improve their sleep duration. The other thing that we always remind our colleagues, especially when they prescribe hypnotics, is to be very attentive to the half-life of the medication, how long they last in the bloodstream. Avoid drugs that last too long because then you're going to wake up very groggy. Or avoid drugs that don't really have sufficient activity and duration. So if someone uses a drug that only lasts for an hour, where a patient has an insomnia issue at 3 in the morning, that's not going to be sufficiently long enough to improve their insomnia. We want an ideal time to have the patient take their medication, the medication to exert its activity, but have it sufficiently long enough to cover the patient when they're experiencing insomnia. And I think at this point I'd like to end the formal presentation. And I know that some of you have questions that you have tweeted through our UCLA website. And please take a few minutes to log in and submit your questions, and we'll entertain them for the next 10 minutes or so. Thank you very much. This concludes the formal presentation, and we'll now turn into the question and answer session. So one question that we usually get is, what about the use of melatonin for sleep? Well, the data on melatonin is very interesting. Melatonin is actually a neurotransmitter that's your body produces, and it's something that people can actually buy over the counter. The only problem with melatonin for insomnia specifically is the timing and the dose are not really well established, especially for insomnia. There's a new medication, relatively new medication on the market that's a melatonin receptor agonist. It actually binds to the body's melatonin receptors that's approved for sleep initiation insomnia. The name of the medication is Romeltian. Romeltian is indicated for folks who have difficulties falling asleep, and they take it before bedtime. It's actually very effective to help improve sleep duration. How frequent, here's a question, how frequent is insomnia in the general population? Well, the incidence is about 1 in 10. 1 in 10 people have chronic insomnia. More like 30% of the population have insomnia at any given time. So it's pretty common and frequent sleep disorder. But interestingly, not a lot of people present to their physicians talking to them about insomnia because they have so many other but medical issues to review. Here's another question, which is when should you see a sleep physician, or when should you have a sleep study to evaluate insomnia? Well, as I've mentioned earlier, insomnia is really not a diagnosis we make based on a sleep study. It's a diagnosis that we make clinically, meaning that we see the patient, they complain of insomnia and have daytime consequences. That's a clinical diagnosis. You don't really need to do an expensive sleep study to diagnose it. However, if the patient snores, if they stop breathing at night, if they kick their legs at night, and the leg movements are disruptive, that's a really important issue. Those are important symptoms to evaluate further by doing a sleep study. Specifically, we're looking for sleep apnea. When we treat the sleep apnea with a continuous positive pressure therapy, that's the CPAP, sleep quality improves, the insomnia improves, and likewise when we treat the leg movements with specific medications, they're less disruptive and the patient can actually have improved sleep duration. Here's another question here is, what about using over-the-counter medications for insomnia? Well, depends which over-the-counter medications we're talking about. And let me give you an example. If you're using Tylenol PM or Advil PM, and you're using those substances every single night, well, you're going to have, probably you may have improved sleep, but you're using these drugs that also contain a lot of Tylenol, acetaminophen, and Advil, which is a non-steroidal anti-inflammatory drug that over a long period of time, every single night, can damage your liver, in the case of a Tylenol PM, or can damage your stomach and kidneys, in the case of a Advil PM. The PM formulation is using diphenylhydramine, which is an antihistamine. The problem is those compounds that use the Benadryl compound can make you very groggy and can actually, in older adults, have a paradoxical reaction, which actually insomnia becomes more severe, interestingly. It's a paradoxical reaction, but those are substances you should never take on a regular basis. If you have an insomnia once a week or once a month, and it's usually associated with pain, and using those substances on a maybe once a month basis is okay, but never on a regular basis, on a nightly regular basis. Here's another question. What about using antidepressants for insomnia, like a drug like trazodone? Those drugs actually never have been studied specifically for insomnia, and I wouldn't really recommend them for older adults because they do tend to cause your blood pressure to drop, your EKG to actually undergo some changes. There is also issue of fatigue and sleepiness the next day, and the side effects sometimes are too frequent to really make them, provide them as a recommended dose, medication every single night. I'll conclude with the last question, which is how to treat insomnia in young children. Well, in kids, I think insomnia is frequent. It's usually associated with some other behavior that the child associates with sleep onset, like having their parents read them a book. We call that sleep onset associated insomnia. But we really don't have good treatments for insomnia or really good trials or specific medications that are approved in children. And that remains a challenge for everyone because we just don't have any good safety data. But if you do, if your child or you do have insomnia and you're less than 18 years of age, I think that's a time in which you should definitely see your pediatrician because we know there are some behavioral treatments that can be very effective. And on that note, I think our time is up, and I'd like to thank all of you for attending, and have a good night's sleep. Thank you very much.